Today's seminar on rapid creation of a COVID-19 ICU, which is the need of an hour in today's world with the pandemic in its full strength. First, let's come to realize what's an intensive care unit. An ICU is called as a hospital's hospital. This is a separate area for care and treatment of very sick patients in a hospital where all the expertise is available and all the gadgetry is available. There are special staff who can work in this area which are of varying specialities. It has special equipment. However, this is a very stressful environment for both patients and healthcare workers, and it's not uncommon for both patients and healthcare workers to develop psychiatric problems after they have either stayed in an ICU or worked in an ICU for a considerable amount of time. As far as COVID is concerned, a ICU which could be used for COVID should concentrate on three things: infection control, isolation, and protection of the healthcare worker. One must realize that 20 to 30% of COVID patients from the data which is available would require hospitalization, and out of which 5 to 11% will need ICU care. And out of these 5 to 11%, 1 to 2% or even more could need ventilators or respiratory assistance. How can an ideal COVID ICU be? One must realize that it's an infectious virus which is causing all the problems. So that area which is going to be made into an ICU should be segregated from other patient areas. You can't have a COVID ICU near a surgery ward or a medical ward or a gynecology ward. One should look for an area where one could really make a separate entry and exit from that area of the ICU. There could, if it is not on the ground floor, there should be a dedicated lift or guarded stairs. A separate entry and exit is important because once a healthcare worker enters the ICU after putting all the protective gears, he should be going away from the ICU by a different way so that there is no mixing up of a patient who's a healthcare worker who's coming and who's going. Ideally speaking, such ICUs should have cubicles where single patients could be housed, or they could be beds with a spatial separation. If one looks at the ICU spacing, one ICU bed usually requires about 12 to 25 square meter of space, and there should be 1 to 2 meters of space between two beds so that various ICU management strategies can be best done. The total ICU area should ideally be 3 times of the total space of the beds, and this holds good for all ICUs, including the COVID ICU. We come to the requirement, and one must realize that one would need oxygen outlets, air outlets, and vacuum outlets or suction outlets. Along with this, for every bed, what is required is 12 electricity outlets to run all the gadgets. These are ideal specifications. However, when one is making an ICU in short span of time, one could compromise on the number of electricity outlets, but there should be no compromisation on oxygen outlets and an air outlet. Also, there should be provision for invasive and non-invasive physiological monitoring. There should be a multidisciplinary team treatment with organ support systems, and as far as possible, one should try to get hold of point of care investigations in a COVID ICU along with an efficient laboratory support. Point of care investigations are important in such a scenario because the area is infected, the atmosphere has some kind of aerosols around, and if we can carry out investigations by the patient's bedside or in the ICU, then it prevents a lot of problems which are involved in logistically transferring samples and getting the reports. A very important part of this ICU has to be an expert nursing care which should be available at all times, and the bed ratio of the nursing staff and other paramedical staff has to be standardized as per the facilities available at that place. One can talk about a bed nurse ratio of 1:1 at all times, but working in India, one realizes that it becomes impossible to have that. But in case one can gather that, it would be an excellent. So once when we are thinking of creation of an ICU, which is in a short span of time, an air conditioning problem is there, which one must understand and one must cater to. Uh, Ideally speaking, the atmosphere or the air in the ICU should be sterile, should be having a low velocity of flow, and the relative humidity should be between 30 to 60%. For one cubicle, that's what when there is one bed, there should be at least six air changes, out of which two air changes should be of fresh air per hour, and there should be a positive pressurization in the ICU. This is at times difficult to achieve when one is talking about making ICUs in an already functioning hospital. So the easiest way is to dedicate or segregate AHUs, air handling units, to that area where an ICU is being planned. Also, what could be done is that special HEPA filters could be fitted, if possible, on these along with these dedicated AHU units, which increase the efficiency of sterilization of the atmosphere. The air conditioning is one thing which is given less importance in our country, and it is not all about just cooling the air, but it is more about cycles of fresh air and having air which comes in which is sterile. Special issues of COVID ICUs, one must realize, is that there would be a lot of aerosol generation in these ICUs, in these patients who are there, and these aerosols are generated during during intubation, extubation, all other procedures like fiber optics, taking samples, bowel samples whenever the patient coughs. All these will cause a higher viral load, and at times one would prefer to have negative pressure in the atmosphere so that these aerosols and high viral load can be removed from that area where the healthcare workers is working. A lot of air conditioning issues have caused problems when new ICUs have been built, because many healthcare workers are not comfortable working with these high viral loads. So as far as possible, even in a already commissioned HDU or an ICU which is being turned into a COVID ICU, there should be ways where we can increase the the rotation of the air and cause some negative pressures. At our place, we have had a unit which we had to convert it within a few days. So we've put some multiple exhaust fans near the windows, and that air from that exhaust fans goes out. But one should realize that these exhaust fans should be put at a place where the air which is thrown out is not near the kitchen exhaust or near the parking area. There has to be a space of about 25 meters, 20 to 25 meters beyond that ICU wall where these multiple exhaust fans are placed, so that people going outside are not infected. There can be instances in our country where these things are not available. The air conditioning is for the whole building, or they are just window air conditioners, which are all the more a problem. So the best way to do is that one can allow natural ventilation to take place. If there are large windows on opposite walls, they should be opened, and so that there is some kind of natural unidirectional flow and air changes take place. When we have such a epidemic happening, we need to make high dependency areas or ICUs in whichever places we can do that, and one must not postpone to have such areas to take care of patients because of non-availability of dedicated air conditioning. So once we've talked about the space, what is important is to talk about what I have categorized into a hardware and a software of an ICU setup, which includes the COVID ICU, and then safety gears, and the importance of support demands can't be undermined. And there are certain specific issues limited to India, which I'll take it up here, and the rest I'll talk about later. In India, still we have seen in the recent past that if you have patients who die in a ICU, which even is a COVID ICU, there is some violence against doctors, and one must be very clear. Then one, if you have COVID ICUs where the mortality is going to be high, as per the world literature available, uh, enough security for the doctors, for the healthcare workers, for the nurses, for the sanitary workers be available, and the local police must be roved into it before you commission an IC. When we talk about the hardware, what I meant by hardware was the oxygen points, air points, beds and trolleys, which would be there as per the requirement or the space available, monitors. These are standard things which are there in all ICUs. Specific for setting up a COVID ICU would be that each ICU unit should have a portable X-ray machine, so that the patient doesn't have to be taken out of, an infected patient has not to be taken out on the corridors of a hospital, going to the radiology room where more and more PPs will be required, and if that area becomes infected, it would have to be disinfected all over again. So portable X-rays, which is dedicated to that COVID ICU, is a very essential piece of equipment, and so are ultrasounds. It has been suggested that patients who deteriorate should have a X-ray done by a portable X-ray machine at time zero, and then the rest of the treatment is done depending upon the ultrasounds, which pick up anything and everything which is happening in the chest. It's very rarely required to shift a patient to the CT rooms. MRI is a big no, but most of the times these patients can be managed with a portable X-ray machine and a good ultrasound. Other than these, every place should have their own protocols regarding intubation and intubation aids available. Each one of us has seen the literature, and they talk about video laryngoscopes. We have it at AIIMS, but then every place cannot be so lucky to have so many video laryngoscopes. So I would suggest that one must use the standard laryngoscope if a video laryngoscope is not available. One must carry out dry runs, simulations on mannequins if available, so that there is a comfort level among the residents, among the doctors who are going to intubate these patients who are generating a big amount of aerosol at the time of intubation. The devices which are available are kind of boxes made out of transparent sheets, or a simple polythene cover which is put over the patient's face and the mask and the body, and intubation is carried out below it. I don't plan to describe the details of intubation in these patients, but one must have a plan A and a plan B for all such patients. Similarly, renal replacement therapy devices, if possible, should be available in this area, because a lot of patients are known to develop renal failure in this subgroup of patients. Then we come to the software, and software is equally important because it is a huge amount of things which we have to be taken care of, and there's so many things which are very essential. Most of these are there in all ICUs, but I want to highlight or stress upon two things. Closed suction catheters are on. One should not be doing open suctioning of the patients who are intubated or on ventilators. And then, because of this pandemic, it could be a distinct possibility that there are not enough infusion pumps, or if they are there, they are only for the first few patients, and the rest of the patients don't get it. So what we have done at a place, because we are preparing for the worst case scenario, and we are hoping a surge never comes in, but if it comes, and if we run out of infusion pumps, we would be using burette sets. The burette sets are the ones which I'm sure all of us would have seen in earlier days, or when we are giving fluids to neonates and pediatrics. So we used to count the number of drops which fall, and there would be 45 to 60 drops per ml, so one can regulate inotropes by these burette sets. They are not ideal, but they are better, and it is better to use these than the normal IV sets if one has to give inotropes in a worst case scenario. The rest one is what is available: medications, IV fluids, both crystalloid, colloids, and nutritional solutions, which are there in all the ICUs, should also be there for a COVID ICU. We come to the next part, which is human resources, and this is very important. We all have various human resources. We all have various doctors, nurses, technicians, orderlies, and sanitation staff working in an ICU. But what is special in a COVID ICU? And this has to be done in a very judicious manner when you set it up. The team composition is important. There's a lot of panic in the doctors, in all healthcare workers. Nobody knows and what is to be done, how he or she has to behave, what happens to their duty hours, what happens to their quarantine. Everything is a big question mark, and there is with the so much of information available on the net. There have been instances where nurses, doctors, technicians are volunteering not to work, and they are citing their diseases or other reasons for not being part of the COVID ICU. The only thing which I say at this time is it all depends on a team leader. He has to be talking to them before you really commission the ICU. A couple of minutes or maybe half an hour to 1 hour, morning, evening, talking to them, convincing them that it's all a part of a big team which is going to work for the country, and all possible preventive measures would be taken care of when a team is made for a COVID ICU. It is important at this time to impress upon them that all possible team workers in an ICU would be getting protective gears as per guidelines which have been there or which have been advertised from America, UK, or Australia. There would be no worker who would be exposed because of lack of availability of protective gears at a given point. It is very important, and it is all important for the team leader to talk about all this. Also, at the same time, the team leader has to talk about the the team leader has to make a command structure and has to ensure that there is a graded exposure to infective atmosphere of the ICU among his team members. The world literature has told us has that about 15%, anything between 13 to 20% of healthcare workers, including doctors, nurses, everyone, could be infected by this virus while working in an ICU. So one has to form a command structure that if something happens to a team member, who is the next one to come in? And this is where a graded exposure scheme is best used. One should not be having all the people available for an ICU duty to be working continuously. One could use just about 5, 7, 8, 10 members. They work for about 7 days and they are sent back home, and the next 10 people come in. And if somebody is exposed, somebody is unwell, so he drops out and the rest can take in. It's better to have one team member dropping out of a bigger team than to have everybody getting exposed or multiple people getting exposed, and there would be no manpower to work for subsequent. A big word about safety gears in a COVID ICU. Once when we set up a COVID ICU, this is one thing which is a bottleneck for all of us. Personal protection equipment is very necessary for all people working in the ICU. The tasks have been defined, the level of personal protection has been defined, and the worst being or the highest amount of protection required is for a person who's doing intubations, extubations, and doing a fiber optic procedure, taking balls or other samples from the respiratory tree. One must remember that one has to rationalize the available PPE to the right persons so that they last for a long time. The world over, there is a shortage of personal protection equipment, and if one would use it irrationally, then a time is likely to come when we are going to run out of it, and it will be very tough to work in an ICU setting. It is very important before you set it up, before you start getting patients, that you have workshops which explain to the healthcare worker, from a doctor to a sanitary worker, how to wear this personal protection equipment of varying level. Personal protection equipment can be level 3 or level 1. So everything has been decided. So one should know how to wear his or her level of personal protection equipment, and how to wear it, and where to wear it, and how to go about in that hospital to the various ICUs. Those routes should be demarcated and defined. Again, doffing is the most critical part of the whole scenario as far as wearing these uh, protection gears are concerned, because doffing is the time when the whole gadgetry is infected by the virus, and it has to be taken off in a right way and then discarded in a right way, so that the body doesn't touch an infected surface. By donning, it means that one is wearing these as per the protocol for personal protection, and one dons all this gadgetry when he is in a safe area or a clean area. Once you go to an infected area and you come out of the infected area, then your gown, your headgear, your glasses, your shields would all be infected, and they have to be taken as described as per a protocol, and somebody must be there to see it and guide everybody at a given time. So for the first few weeks, we are going to ensure, or it should be ensured, that there is somebody who's overseeing the donning process for every healthcare worker, and there is also somebody who's seeing the doffing process of every healthcare worker. There should be a universal institutional policy regarding doffing, donning kind of PPEs, which would give a plenty of confidence and boost the morale of a healthcare. What is important in a COVID ICU is that other than the standard treatment modalities which would be there in all ICUs at all levels, we are not only talking about ICUs at a tertiary care center, we are also talking about ICUs at district level hospitals, at places where there are no ICUs or only HDUs or only isolation wards which are to be converted to ICU. One thing which should be ensured, and one thing which is going to work, and one thing which is going to save a lot of patients, is that every ICU who is going to admit COVID patients, there should have a provision of proning patients. It has been seen that by proning patients for about 14 to 16 hours at a given time, a lot of patients are salvaged. Hypoxia improves, the oxygenation improves. It has even been advocated that if you have a patient who's breathing spontaneously, who's not intubated but is requiring oxygen therapy, he or she should be advised to lie prone. I know it is difficult, but there is enough data to show us that if patients are able to lie prone even when they are breathing on their own, or with supplement oxygen, the oxygenation is better. However, proning, once the provision of proning is there, then the staff available there should be geared up to the procedure of proning, to take care of a prone patient, to see what all medications are required for a prone patient. It's a separate topic in itself, but when somebody is setting up an ICU for COVID patients, availability of proning these patients for long hours, anything between 12 to 16 hours, is very necessary. Various ICU protocols would have to be modified when we talk about COVID ICUs. The treatment protocols, giving of antivirals, avoiding a lot of blood cultures, because there would be apprehensions in the lab workers to touch even secretions and blood of these patients when you send it for lab cultures or hematology or biochemical investigations. So many protocols of the ICU would have to be modified. What we would do is, if we need to intubate a patient, we'll intubate a patient and then start antibiotics as per a protocol, and antivirals as per a protocol. And the best part is that these protocols keep on changing. They have changed in the last 2 months. So they will keep on changing. So a protocol would have to be made for a given ICU, and one has to decide that this protocol would be changed after 6 or 7 days in consultation with the infectious disease team or anybody else. Similarly, CPR guidelines have changed for these group of patients. One must not do a CPR unless one has a proper PPE in place. So these guidelines would have to be present before a COVID ICU is started. A very important part of this ICU would be record keepings, whether one would like to have a paper record if an electronic record keeping is not available, and I'm sure this is not available in most of our ICUs in the country. If it is there, then there should be a dedicated team member who would be in charge of the record keeping, so that he can put in the right numbers and it goes to a central lab, a central registry. If your patients are stable, if uh, you have team members who are more in number and they are not required inside the ICU, so one should decrease the number of doctors present inside the ICU, and the basic rounds could be taken virtually with iPads. Our ICU here, we have acquired some iPads, and with the net connection, if the patients are stable, rounds can be taken by consultants virtually. This will not only decrease the exposure to an infected atmosphere, but this will also decrease the number of PPEs which are being used. And PPEs are again a big problem in acquiring in our country, or maybe everywhere in the world. So one must try to conserve PPEs, and if virtual rounds can do that, these must be carried out. An important issue in an ICU is talking to the relatives. It is very difficult to allow the relatives coming into these kind of COVID ICUs, because they will have to wear some kind of PPE which has been certified to be worn by people visiting these patients. But then the PPEs are less in number, so maybe these patients' relatives could be talked again on electronic media. They could be informed about the patient's condition, so that they need not come to the hospital and do overcrowding. Every ICU, COVID ICU, would have to make his or their own uh, protocols, even for communication with the relatives. They have to be informed about their patients, but then how they have to be done, how the ICU has to be decongested from areas of relatives, has to be worked out. An important thing in these ICUs is whether one should be carrying out autopsies or limited biopsies. This has to be an institutional policy. In cases of deaths, one must be sure that no biopsies or autopsies are carried out unless consenting has been done. And many institutions in our country are taking these kind of consents at the time of admission. This consent and paperwork has to be ensured before any academic related biopsies or autopsies are. An important part of a COVID ICU would be the delivery of food and the way the food is brought to these patients who are not on ventilators, who maybe are requiring just oxygen, or who would be in HDUs but not very sick. The availability of the food, the availability of the kind of food, and the pathway of the food handlers has to be ascertained before the ICU is commissioned. Unlike all other ICUs, the person who is giving the food may not be allowed to come into an ICU area, because that would mean again using some more PPEs and discarding them, and have a potential of infection for those food delivery boys. So the delivery of food could be at the door of the ICU, could be at a window of an ICU, and the food is taken and then given to these patients, and then the rest of the things are given back. So some kind of pathway has to be ensured before commissioning of these ICUs. Another important thing for starting off a COVID ICU is the medical waste disposal from the hospital. New guidelines of COVID-19 have been brought out by the Indian government, and there have been certain changes. The medical waste disposal system must be in place, like it is in place for our ICUs also. But for COVID group of patients or COVID ICUs, they have changed, and one of the simplest thing which has happened is double packing, and there are so many other things which have to be ensured. It is suggested that these are ensured, they should be on place, they should be, everybody in the system should be able to know how the waste disposal has to take place, how the sharps have to go. They have not got to go the way it goes out from a regular ICU. So one can assess these new Indian guidelines regarding COVID-19 from the net, and all healthcare workers should be sensitized about them. At this time, I would like to talk about two issues. One is ventilators, and the other is splitters. If you have seen lately, a lot of ventilators are now available in the market, and every day ventilators are being made, and information sent to all healthcare managers to buy the ventilators. They are available in all shapes and sizes because all news items coming from the West, from America, from UK, from Italy, from Spain, they always are talking about not non-availability of ventilators. One must realize that ventilators needed for COVID patients would be for patients who have developed respiratory failure, who have developed ARDS. And a normal, simple ventilator cannot ventilate patients who would have ARDS. So one must ensure, one must test before investing a lot of money on ventilators that a particular type of ventilator can be used in patients who have stiff lungs, who have a lot of fluid in their lungs, who have ARDS, which is severe. So unless the ventilating device can ventilate these patients, it is no use to spend money on them. The second thing I want to talk here about is splitters. They are again in fashion. Everybody has seen a lot of WhatsApp videos. They have been used in Canada. They have been used in various other countries. They are basically Y connections which are attached to various limbs of a ventilator so that two patients can be ventilated at the same time. It looks so simple, but it is not. In my opinion, splitters are of no use because of various issues. We have tested these splitters on various ventilators in the lab using calibrators, and we found that they just can't ventilate patients with different compliances adequately. Every patient would have a different weight, a different condition of a lung, a different requirement of FiO2, and you can't really have something like one size fits all. Another important thing is when we use splitters, though you use filters, you could say that filters would avoid infection, but it's very difficult to avoid person to person infections. At the most, one could use a splitter in case one is giving some end of life care. So I am personally against use of splitters and using one ventilating device on 2 patients or 6 patients or 8 patients. They could be used if you've seen those videos, if you know something about physics, you can well imagine that if you have normal lungs, maybe you could have a tidal volume of 1000 ml, and you could come down on a piece of paper saying 500 ml of tidal volume would go to both the experimental lungs. But the moment the compliance changes, all goes haywire. So splitters are a big no. Ventilators you must have, you must stock, and you must try to have the ones with which you would be able to ventilate lungs which are not healthy. Another issue coming here is infection risk of the ICU personnel. I have already talked about the number, about 15 to 30% will get infected, but one has to accept this number and one has to ensure that proper donning and doffing, especially doffing, is done so that the infection rate is less, and all aerosol creating procedures like I've already mentioned, intubation, extubation, fiber optics, tracheostomy, surgical procedures, every healthcare worker is adequately dressed up so that the chances of infection are less. Another frequently asked question is about prophylactic use of hydrochloroquine in these group of patients. In the Indian setup, Indian Council of Medical Research has advocated the use of hydroxychloroquine in healthcare workers managing these patients. However, there is plenty of literature which is against their use, and there have been some instances where arrhythmias have been seen after their use. In our ICU, we have procured hydroxychloroquine, and most of the doctors have been advocated to take it in case they want to have it. It is not mandatory in our ICU that every healthcare worker should take it. It is up to each individual to decide to take it or not. Then there are issues of regular quarantine after a few days of healthcare workers, and there is a big problem regarding this in our ICUs, and I'm sure this will happen in other ICUs also. As per the Indian guidelines, regular quarantine is not become a standard. It's not a state when we can really ask 6 people or 10 people or 15 people to work for 7 days and go back and take time off for 14 days and come back after that. We really don't have that kind of manpower to advise quarantine. Quarantine should ideally be given to all people who get infected, who get exposed, or there have been some breach of sterility and uh, a lot of apprehension which follows that. Regarding testing for COVID-19 for healthcare workers who have worked in ICU, again there is no guideline which mentions it. If testing is not advocated for healthcare workers unless they have some symptoms or they fall into criteria of being tested. There is a shortage of testing kits, and one must appreciate that we should not be wasting them. Another important issue which I have seen in my ICU, which you recently set up, is that every person is, including doctors, is apprehensive about carrying infection home. And they all want to stay in the hospital settings. Certain state governments have advertised, have made press conferences where they are advising advertising for rooms where healthcare workers can stay back. But in our ICU, in our institution, we really not have implemented this because of shortage of space. Because if we decide to give accommodation to healthcare workers working in an ICU, we would have to give it to all healthcare workers. So what I have done is that I try to convince people. I try to convince various level of people, from sanitary worker to a doctor, that he is unlikely to carry home infection if he's followed all protocols, he's well clothed, and he's wearing a proper PPE for that given area. And it's better that he doffs off, takes a shower before doffing off, changes off into his own clothes and go home. It's very unlikely he is going to carry home infection, even if uh, uh, he has diabetes or has some other disease or has old people at home, his parents. Only 3 risk factors have so far been documented, and that is age, sex, and hypertension. And that too, there's a lot of varied literature regarding use of AC inhibitors and ARBs. So the jury is still out regarding their use. But the risk factors are only these. I like to conclude by just emphasizing that in this epidemic, one must be very clear that whatever I have said is needed, but ideal circumstances may not be present for all of us. And in spite of that, we'll have to it's a duty to take care of our patients, and let's try to use our sources, our available gadgetries to an optimal level so that we can protect ourselves. However, isolation and location is essential, and if one can do that, it can prevent a lot of cross infection in other hospital staff or other areas of the hospital. One must think about air conditioning. We may have a suboptimal air conditioning system, but we could generate negative pressure like the way I have told you. Or if there is no air conditioning, or the air conditioning cannot be isolated, we can switch it off, open the windows if there is enough of cross ventilation available. But at all times, protection of a healthcare worker is of prime importance. And unless we can protect our healthcare worker, I think we cannot expect them to do a job which is efficient in taking care of ICU patient at this time. We have seen videos which have come from various European countries which are very scary, but luckily this has not happened in India, and we can still do a lot of things. We still have some protective gears which we can use optimally so that our healthcare worker is not infected. Lastly, doffing after doing your duty, after you have worn your healthcare protective gear, is very important. And doffing, one must to be very careful so that no infected surface comes in touch of a healthcare worker which can give rise to COVID infections.